Good morning, afternoon, evening, everyone. Thank you so very much for joining us today. Whether you're joining from near or far, we're thrilled to have you here for this exciting presentation. And all the greetings are taking into account that we are all over the country, and I'm hoping that everybody from all time zones are able to make it to this talk. My name is Deb, and I'll be your host for today's session. And we have a truly engaging and insightful presentation lined up for you. And we are confident you'll find this information shared today very valuable. As a reminder, this is recorded, and you can revisit this on our YouTube channel whenever you want to. Before we dive in, I'd like to cover a few housekeeping items to ensure that you have the best possible experience today. If you have questions throughout the presentation, please feel free to use the chat feature, and our team will be monitoring from the background. We will hopefully have a little time for a Q&A session at the end, and we encourage you to actively participate. Now let's talk about what we can expect today. We are honored to have Dr. Owosho, who is a professor of oral and maxillofacial pathology and oral medicine at Mosto, and the rockstar clinician researcher we are so proud to have in our community. This is the first of the two series of seminars by Dr. Owosho on the use of real-world data in oral health research. We are certain that his insights will help you gain a deeper understanding of orofacial adverse events in immune checkpoint inhibitor treated patients. So we are so excited to get started, and let's just jump in. Dr. Owosho, I will hand it over to you. Thank you for being here today.
Thank you very much, ma'am. Thank you to ATSTO Research Institute for the opportunity to share some of the studies we've been able to do using this real-world data set, which is basically called TriNet Hex. TriNet Hex is a compository of about sometimes actually up to 150 hospital health cares from all over the continent, from different countries. And in that data set, we could pull close to 150 million patient information. And these are real time. This is a real time data set that every day it's been updated. So if you pull data from it last month for a particular entity and you pull data from it this month, definitely there would have been an increase in number of patient cohorts in what you're looking at. So it's a very wonderful data set that we've been utilizing for the past 1 year. And from this data set, I've been able to publish about 10 publications from this data set. So it's been very, very worthwhile. Well, today, thank you all for coming to listen to this talk. We'll be talking about investigating the prevalence of orofacial adverse events in immune checkpoint inhibitors using this large data set. Again, my name is Adepitan Owosho, and I'm with Mosdo ATSTO University. So this is the paper that was published, where this presentation is being gotten from. And as you can see, this was just recently published this month in the February edition of the Quadruple Journal of 2026. A little bit about me. I'm a dentist. I did my dental school in Nigeria. Did my pathology training at the University of Pittsburgh in Pennsylvania. Did my dental oncology clinical research fellowship in Memorial Sloan in New York City. And I'm also a board certified pathologist by the American Board of Oral and Maxillofacial Pathology, a fellow of the same Academy of Oral Pathology, and also a fellow of the American Academy of Oral Medicine. And recently also got inducted into the Academy of Medical Sciences. My area of research focuses on two major areas, the molecular and immunophenotypic analysis of head and neck neoplasms, ranging from salivary gland tumors to odontogenic tumors to squamous cell carcinomas to all the major broad cancers involving the head and neck region. And an area that is also very interesting and dear to me is the management and prevention of oral adverse events secondary to oncologic therapy. So, just a little background into oncologic therapy, how oncologic therapy has kind of advanced over the centuries. As you can see, way back from 3000 BC, surgery was the main therapeutic option for for cancers, for neoplasia. Surgery was the main thing. And obviously, thanks to Marie and Perry Curie, we were able to have radiation X-rays. Radiation therapy was then brought into board in the 1900s. In the 1940s, then we started having chemotherapy, such as the methotrexate, 5-FU, 5-fluorouracil, cisplatin, doxycycline to cetuximab. So, and those are the major therapeutic medications available now to oncology patients. In the 1980s, we then went on to the use of targeted therapies, which is really nice because not all tumors are the same. And interestingly, even though I do say not all tumors are the same, tumors of different organ origin could actually have similar mutation driving them. And being able to know what the genetic mutation that is driving a particular tumor, you can then specifically target that particular gene. And many instances and wonderful innovation has come out of this. A good example is the TKIs, tyrosine kinase inhibitors, now being used to treat multiple tumor types, right from CML to GIST to non-small cell lung cancer to various cancer types right now. And recently in 2010, through the help of Dr. Harlinson, we recently actually won the Nobel Prize for Science for his discovery of an immune checkpoint inhibitor, specifically the CTLA-4 was what he was able to they identify the inhibitor for CTLA-4. Now we have what we call the immunotherapy, specifically the immune checkpoint inhibitors. And one of the very first set of malignancies that were treated with this is melanoma. And in patients that do respond to this, they respond very, very well. There's a very, 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 very good prognosis when they do respond to this treatment with immune checkpoint inhibitors. And, beyond just melanoma and other cancer types, we've also seen that, right now, the FDA has approved 20 different cancer types are being treated with immune checkpoint inhibitors. And also that also includes head and neck cancers, which is my area of interest, being a dentist. And the first approval by the FDA for head and neck cancers was in 2016. We'll talk more about that as we go on. So what are immune checkpoint inhibitors? Basically, these are a class of monoclonal antibodies. And this is a situation whereby ideally the body T cells, the CD8 type of the T cells, which are the cytotoxic T cells, their responsibility basically is to destroy any foreign material, any foreign body. So when a cancer cell comes into, is in the body proliferating, ideally our T cells, the CD4 type, the CD8 plus type, ideally goes there to try to initiate destruction of these cancer cells. But unfortunately, what has been happening is that the cancer cells are able to block the inhibitory area of the T cells, thereby making the T cells not being able to either recognize the cancer cells or not making them to release their cytotoxic response to the T cells. And with that happening, you have T cells in there and you have tumor cells in there, and the T cells are not able to carry out their function. So they just reside in the same tissue stroma, not really doing anything much in regards to the cancer cells. Now, and that's because, like I said, the cancer cells, they're kind of intelligent in the intelligent cells, releasing these things that kind of inhibit the action of the T cells. But with the aid of these immune checkpoint inhibitors, specifically, we have four major types now, I should say: the PD-1, the PD ligand 1, the CTLA-4, and the LAG-3. With these inhibitors now, the inhibitors, as you can see now, would literally go between where the tumor cell ligand that is trying to incorporate into the PD-1 receptor of a T cell, thereby inhibiting the function of a T cell. With the presence of this inhibitors, checkpoint inhibitors, they go there to prevent this interaction from happening. And once this interactions does not happen, it makes the T cell to be able to carry out its function. and which is then be able to, release cytotoxic enzymes or, immune signals to then destroy the cancer cells. And that is what it does. So basically, in a short form, immunotherapy is basically a way whereby the body's own T cells are being optimized to then destroy the tumor cells. So basically, you're using your own body's T cells to destroy cancer cells by removing that inhibitory effect and allowing them to be able to carry out their function, which they should be doing originally there. Like I said earlier on, the FDA as right now has approved 20 different solid tumors that are being treated with ICIs, immune checkpoint inhibitors, ranging from melanoma to Merkel cell carcinoma. My next slide will show us a full list of these cancer types. And these immune checkpoint inhibitors currently are being used as monotherapy, being used alone, or they could be used in combination with surgery or chemoradiation also. So here's a list of immune checkpoint inhibitors and the various tumor types that are being used for. So look at the PD-1 inhibitors. The common example is the pembrolizumab. I'm sure you guys have seen on TV commercial Keytruda, and that's what that pembrolizumab is what we call Keytruda. That is the brand name, the generic name being pembrolizumab. Mainly used for melanoma, or initially being studied for melanoma. You can see it being used for non-small cell lung cancer, head and neck squamous cell carcinoma, Hodgkin lymphoma, bladder cancers. Then we have nivolumab. Again, you've probably seen a TV commercial on this medication, the brand name called Opdivo. Also treats melanoma, the same non-small cell lung cancer, renal cell carcinoma, Hodgkin lymphoma, hepatocellular carcinomas. Then we have the other examples there. Then you go to the PD-1 ligand inhibitors, we also examples and the various cancer types that they do treat. CTLA-4, the main example here is the ipilimumab. Again, ipilimumab primarily used to treat melanoma, now also being used to treat renal cell carcinoma patients. Then we have the LAG inhibitor. This is relatively new and also now being used in combination to treat melanoma there. So these are all the major classes and examples of immune checkpoint inhibitors and the cancer types that have been used to treat. The objective of our study, when we did the study, was basically to characterize the prevalence of orofacial immune-related adverse events in patients who are currently using immunotherapy, ICIs, as a form of monotherapy. Because one of the things one has to do is that these complications that could arise from using ICIs can also be seen in patients who are using chemotherapy or using radiation therapy. So we needed to make sure that we were specifically looking at patients who are just on this immune checkpoint inhibitors only, so that we can actually characterize and say this oral adverse event was seen is solely because of immune checkpoint inhibitors and not from chemotherapy, not from radiation therapy, not from TKIs, but specifically from pembrolizumab, ipilimumab, and the other examples, okay? And there, using the TriNetX network, the database, as you can see here, from 11 countries, we were able to get data from 106 healthcare organizations. That's a large database, as you can see. And and our exclusion criteria were patients who are under 18, patients who are currently using chemotherapy or had radiotherapy being used, radiotherapy specifically for head and neck radiotherapy. Then also our, basically every other patient that had been on anti-PD-1, PD-L1, CTLA-4 that are above 18 was our inclusion criteria. In addition, we also excluded patients who had pre-existing orofacial conditions. So we had a particular set of orofacial conditions that we were looking at, which were categorized into 3 broad outcomes: salivary dysfunction, oral mucosal disorders, and orofacial neuropathies. Those were the 3 broad adverse outcomes we were looking at. So any patient that had a pre-existing diagnosis of those conditions were also excluded, because again, we wanted to make sure that it was secondary to the use of immune checkpoint inhibitors and not a prior diagnosis of this outcome. With that being said, this is our flow chart. As you can see from TriNetX Research Network, our total number of patients in that TriNetX research as at when we did the study, because now it's way more than 153 million. there was 153 million patients. That's a large database. And from there, after including our inclusion criteria, we came down to 163,000. After including our exclusion criteria, it came down to 15,000, approximately 15,000. Now, after that, we then excluded those that had a pre-existing adverse outcomes. Those were excluded. Then we then went on to look at our outcome analysis. So our patient cohorts, as you can see here, were patients, obviously male-female ratio, more of males. The average age was 70, with the standard deviation plus or minus 14. When we looked at the race, ethnicity, we kind of saw the patient population was way more Caucasian out of our 15,000. And then Asian population was the next, and followed by African American, Blacks, in that category and the other groups there. When we looked at a particular immune checkpoint inhibitors out of our 15,638, majority of them were on pembrolizumab, which is 47%, followed by nivolumab. The other the other ICIs, as you can see, their breakdown. The most common diagnosis for patients that were treated with this immunotherapy, these ICIs, as a monotherapy, the most common was for skin cancer, followed by urinary cancer, followed by lung cancer, as you can also see there. Now, like I said earlier on, our adverse outcome was broken into three broad categories. And the broad categories again are orofacial neuropathies, oral mucosa disorder, and salivary dysfunction. In the orofacial neuropathies, we were looking at dysphagia. Again, remember, our focus was orofacial. So we couldn't just put everything in there. We had to focus on orofacial region, mainly in the oral cavity and facial manifestations also. So we have dysphagia, which is basically difficulty in swallowing. We have facial numbness, trigeminal neuralgia, dysgeusia, which is taste alteration. Aphasia is actually inability to swallow, and also glossodynia. So those are the categories of orofacial neuropathies that we did evaluate for. Under the oral mucosa disorders, we looked at oral lichenoid drug reaction, which I will show you clinical images of what this looks like. We had stomatitis, we had oral mucositis, we also had erythema multiforme in our oral mucosa disorders. Then for the salivary dysfunction, the major thing we looked at was for xerostomia or dry mouth. So when combining all these adverse events together, the total number of adverse events actually made up approximately 10% of our total population of patients. So a total of 1,564 patients out of the 15,638 patients actually reported having one or more of these adverse events, as you can see. Now, if you look at it, if you look at the most common adverse events, when you break them down into three major groups, the most common is actually orofacial neuropathies was the most common, making up 56.97%. And the least common is the salivary dysfunction, making up approximately 9% of the total number of oral adverse events. Then looking at them in terms of raw prevalence, looking at the patients in terms of raw prevalence, like I told you earlier on, we excluded people with prior outcomes so as to have a very clean data. As you can imagine, you can imagine if we did not exclude, you can see column 1, 2, 3, 4. The fourth column had our excluded outcomes, those that had prior outcomes. If we did not exclude these patients, then we would just be inflating the numbers and the prevalence. So we did make sure that we excluded any people that had prior outcomes, and we just stuck with those that only had the outcome after they initiated the use of immune checkpoint inhibitors. So you can see our raw numbers there compared to the total numbers that we had, and you can see what the prevalence is. Interestingly, if you look at the highest prevalence there, the highest prevalence was a case of the cases of people with facial numbness and trigeminal neuralgia. Actually, 3.6 dysphagia is the most common. Facial numbness, trigeminal neuralgia came out to be 1.63. Oral lichenoid reaction, 1.4%. Then people with 1.22% are patients who tend to have stomatitis in the oral cavity there. So I know many of us might say, well, the prevalence seems to be small. Yeah, overall, it does look to be small, but if you're in that category of 1% of patients that has to deal with this adverse event, then it's a big deal. And what I've observed is that most medical oncologists do not really spend time looking at adverse events in the mouth. That is the list of their concerns because there are way more serious adverse events that these patients are dealing with. This ICIs can actually cause pneumonitis, which is a more deadly condition, and that is what they are focusing on rather than looking into the patient's mouth and saying, "Hey, what's going on in your mouth?" So that's very true in most medical oncology practices. So something to for us kind of think about there. Here's an example of a patient that developed what we kind of call oral lichenoid adverse events. And this is a patient on pembrolizumab. As you can see there, you can see areas. When we say lichenoid, we're referring to something kind of whitish in appearance, lichenoid. And you can see areas of erythema also all around the buccal mucosa, on both buccal mucosae, even involving the palate, even involving the ventral surface of the tongue. And for this patient, these were really painful really painful. Patient could not really swallow and not understanding what's going on in the mouth. And I can tell you, but for this particular case, this case actually went on for over 18 months. And the medical oncology group actually thought they thought it was just mucositis. It was just a regular mucositis. They didn't really bother about it. There was really no much concern about it. Interestingly, because this was a case that I did publish, interestingly, this eventually itself led to squamous cell carcinoma. Because when you have an inflammatory condition that is not managed for a long time, that itself could be a breeding ground for cancer. And this particular patient eventually did develop squamous cell carcinoma in the retromolar region, in the figure A right there, that was confirmed histologically. So again, most medical oncology office, they are dealing with other things. They don't really tend to look into the mouth. That's not the focus, but something could be going on within the mouth that they need to pay attention to. And we as dentists or in the oral care field, we need to raise the alarm about this so that patients can get the most, they can get an well-rounded care that they do deserve. Yes, another patient again. Patient here on immunotherapy. You can see the ulcers in the mouth, everywhere on the buccal mucosa, the erythema, and even bleeding. Again, this is from the use of immunotherapy or in managing this patient. As you can see that. These sores are very painful. I actually know this patient. Anytime the patient comes in and develops this, the wife would come in saying that, he's not been able to eat. The only thing he's been able to drink has been Ensure. Apart from that, everything else tastes different. You can't even swallow because it's so painful. Again, this is from immunotherapy or immune checkpoint inhibitors. Other examples, you could also have oral lichenoid lesions. You could just see erythema multiforme, areas of ulceration everywhere, looking, in different, having different appearance or clinical appearance there. Another example of an oral lichenoid lesion on the buccal mucosa there, as you can see. So those are the results we got. And when we submitted this to Quadruple O, which is the journal for oral surgery, oral pathology, oral medicine, and oral radiology, there was a study that they really liked, they appreciated, and it was accepted quickly and it's now published. So our discussion is recent therapies have improved patients with malignant neoplasm outcomes, especially overall survival. And the use of immune checkpoint inhibitors as basically reversionalized oncology treatment. It's now an effective treatment option that is used across many cancer types, and it was first approved by the FDA in 2011, and that was the ipilimumab. That's the anti-CTLA-4, was the first form of ICI that was approved in America by the FDA, and then it was approved for unresectable metastatic melanoma. That was what it was approved for. But now, as at 2005, about 2025, I should say, towards the end of last year, it's now approved for over 20 solid tumor types. So again, right from melanoma, from that's the first tumor type that it was approved for, now to Merkel cell carcinoma, which is a form of skin cancer. Now, let's look at immune checkpoints in head and neck. What has been the progression of this agent? Well, the FDA approved it initially in 2016 for treating advanced form of head and neck cancer. So basically, these were for recurrent or metastatic head and neck squamous cell carcinomas that did not respond to chemotherapy. There was a continual progression of this tumor even while they were being treated with chemotherapy. So that was the first approval for head and neck cancer in 2016. In 2019, this was changed. There was an additional approval by the FDA where pembrolizumab was then approved as a first-line treatment for patients with metastatic or unresectable recurrent head and neck squamous cell carcinoma. Again, it was at that point in 2019, it was still limited. This wasn't for all head and neck cancer patients. Again, it's only for patients who had metastatic tumors or patients who had recurrent tumors that could not be resected. So again, it was still being limited in its use. Now, recently, June of 2025, I must say this because I must give honor to whom honor is due. The folks in Owosho were actually very, very instrumental in getting this approval done. They actually did the study, which is called the Keynote 689 trial. 689 trial. And with this keynote trial, clinical trial that they did, the FDA, as of last year, June, people like Douglas Atkins, and every Thursday, I'm fortunate to be in tumor board with individuals like that, rubbing minds with them and feeling like I know something when I'm amongst them, so it's always an honor to be with them. These are individuals that actually did this trial, and with their help and their study, right now, ICIs, immune checkpoint inhibitors, is now approved as a first-line treatment for any head and neck cancer, any head and neck squamous cell carcinoma. That's a big deal because now it can be used even before surgery. It can be used even before chemoradiation. And, the main reason for the approval was because there was an improved event-free survival. That is, there was no local recurrence, there was no distant metastasis when it was being used. And more significantly is that it actually did help reduce the tumor size, because that's a big deal, especially in the head and neck. The head and neck anatomy is very interesting because the head and neck is very close to vital structures. You think about it. If you're trying to resect a tumor in the tonsil, that is right there. Right behind the tonsil is actually cranial nerve 9, glossopharyngeal nerve. So if you're trying to remove a tumor near the tonsil, you have to be very careful that you're not going to resect or lacerate the glossopharyngeal nerve, right? If you're trying to work on the buccal mucosa retromolar region, right beside it is the salivary gland, and again, even if you're dealing with a base of skull tumor, right at the base of skull, you have the vertebrae there, you have the spinal cord there. So there's so many things. You have the brainstem right there that you have to kind of deal with. So anatomy of head and neck is very, very intricated with a lot of various important vital structures everywhere. You kind of think about it. So being able to have an oncologic agent that you could use to shrink the tumor size before then going for resection, it's a big deal. So based on all this, the FDA then gave the use of pembrolizumab, Keytruda, for a first-line treatment for all forms of head and neck squamous cell carcinoma. So here's an example. For those of you that are skimmish, I'm sorry, but just to give you a practical example, this is an example of a patient who presented with oral cancer. You can see how massive this oral cancer is. In the past, before, immunotherapy or things like this, maybe you could first try chemoradiation to see if that would help reduce the size. Maybe not, maybe it would. But if you were just going to go for surgery on this patient, the patient will be losing more than half of their jaw due to surgical resection. But with the advent of this ICIs now being approved as a first-line therapy, you would probably first give immunotherapy to this patient. If the tumor does respond, That is very important. Obviously, before you even do that, the pathologist, the biopsy would have been taken. They would review it on the pathology to see if they do have the PD-1 ligands, if it's you guys, yeah, we have PD-1 receptors on the tumor, and if there is, then that would most likely show that this tumor is a kind of tumor that would respond to immunotherapy, to pembrolizumab. Then you give pembrolizumab to this patient, this tumor size will shrink, and once it shrink, you can then reevaluate it and say, okay, what do I need to debulk? What do I need to then remove out? And what structures, what vital structures can I save there? Talking about chemoradiation to shrink this, the problem with chemoradiation is that if you shrink this with chemoradiation and the jawbone is right there, that jawbone is completely gone. Because with radiation, that would completely fry the jawbone, that mandible. And that all these teeth in that area that jawbone will be highly predisposed to the risk of osteoradionecrosis. But with immunotherapy, that's not the case. You can still say, okay, what is left after the tumor shrinks and what can be done next? So orofacial immune-related adverse events associated with ICI, has been previously documented. In the literature, there were case reports, case series, single or dual center retrospective studies. That was the highest out there. But with our study, where we brought in large real-world cohort of over 15,000, this actually represented the largest single study of these immune checkpoint inhibitors and looking at orofacial adverse events in these patients, with this large data. Again, specifically looking at ICIs that were used as a form of monotherapy. We excluded chemo radiation because imagine if we didn't exclude chemo radiation, our numbers will be really inflated. And and again, our results though will be compounded, because we can't really rely on that result because patients on chemoradiation also have similar oral complications also. But in this case, we only looked at patients who are just using immune checkpoint inhibitors. So these adverse events definitely do impact the patient's quality of life. And for most oncology patients, that is what matters the most. Just because we are providing care to them and everything, doesn't mean that they would eventually survive. Because even think about it, oral cancer overall survival over the years has really not significantly improved. It hasn't. Especially when you have a stage 3 or a stage 4 cancer, which is called an advanced cancer. Oral cancer has not really seen a lot of improvement in overall survival. So what matters to this patient is the quality of life. If they would still be here for the next 3-4 years, being able to enjoy that quality of life and not being in pain, being able to eat the meal they like to eat, being able to not to deal with these complications is very important and paramount to the patients. Also, when patients start having these oral complications, patients actually would tell you, I've seen patients that will literally say, I can't deal with this anymore. It's very painful. I would like to discontinue my therapy. I've seen patients that have done that several times. Literally unfortunately yesterday, a patient came through the urgent care clinic. It wasn't scheduled. He just came in and, then, obviously doing the history taking, I'd informed our student that, oh yeah, I have colon cancer and I have stage 4 colon cancer, which means it's metastasized to everywhere, it's metastasized to every other parts of his body. And he said, I had to discontinue my chemotherapy because I couldn't deal with it anymore. So that's a real life patient right there that literally came in through urgent care. They were in pain and they had to tell us that, said, I can't deal with this anymore. Because I can't deal with the complications of this medication and everything going on that I can do. And I had to talk to the patient that, you understand what you mean by that. Like if you're saying you don't want to, you want to stop your therapy because of the complication that, that your tumor is going to spread, it's going to keep spreading, it's going to get bigger, it's going to affect you, unfortunately, ultimately, it may lead to death, and he said, yes, he understands, but he's tired of dealing with the complication of the oncology therapy. So this is very important that many patients, especially with oral mucositis is the most common oral complication that makes head and neck cancer patients tell you that I do not want to continue anymore. I can't bear this anymore. I can't deal with this pain in my mouth anymore. So in general, our studies show that 10% of patients did develop orofacial complications, comparable to other studies. The study by Al actually found theirs to be 10.8. Um, so et al. From I think this was a study from Brigham Women Hospital. Their own incidence was 6.8. Ours came out to be 10% with the use of a large data. Uh, Prevalence types. In our own study, the most common orofacial complication were neuropathies, which made up approximately 57% of our reported events. Of those neuropathies, dysphagia, which is difficulty swallowing, made up the largest neuropathic event, followed by facial numbness and trigeminal neuralgia. Previous studies have reported neuropathic adverse events to range between 1 to 12% in patients being treated with immune checkpoint inhibitors. And cranial nerve involvement, it was approximately 7.2 in previous reports. In our study, oral mucosal disorders made up the second most prevalent orofacial adverse events, which range from stomatitis to oral lichenoid lesions to oral mucositis, leukoplakia, erythema multiforme. According to Howe and Hien et al., they reported oral mucosal disorder as the most common. Our own most common was the neuropathic events. Xerostomia was the least common in our patient population. The study by Seravasteva et al. And X et al. Did find xerostomia to be the most common. Now, I think the reason for this is because in our own study, we excluded prior outcomes. In their study, they did not exclude prior outcomes. So I think that that's a big deal because, like I said earlier, if we did not exclude patients with these prior events, we would be inflating our numbers and we wouldn't know if the adverse event was seen was secondarily due to the ICIs or prior conditions. So looking at the onset of when these complications do arise, previous studies have shown that the median onset is approximately at 100 days after starting ICIs. I know many of you are like, oh, 100 days. Yeah. Unfortunately, these medications could be used for up to 2 years when they are being treated with this ICI. So it's not a one-time treatment. It's not like, oh, it's just for 1 week or 2 weeks or 6 weeks. Like a chemoradiation, in a head and neck cancer, chemoradiation is just for 6 weeks, 7 weeks, and that's it. But when it comes to ICI, this is a medication that they would have to use for that approximately 2 years in some instances. So these are long-term medication use. So the first instance of this reported oral event, it was approximately at 100 days. Obviously, there have been reports of earlier occurrence, like literally the day after their first dose of an ICI. The very next day they developed oral complications, and that was seen with oral mucosa disorders. That the very next day they had oral complications involving the oral mucosa. Xerostomia and dysgeusia, also had a similar short time frame before this adverse event did show up. So what's the clinical implication of understanding understanding these complications and also knowing how to manage them? Well, it definitely highlights the importance of having dental professionals as part of the multidisciplinary care of cancer patients. And that's something I like to emphasize when I get to talk with my colleagues. That is very important that dentists are involved in management of these patients because there are some of these things that that we can manage, we can identify, and help with the quality of life of patients. Because imagine if something is seen, if something is diagnosed early on, and as you can see from prior studies, that some of these oral mucosa complications can literally arise the very next day. So imagine if this is detected early on and can be managed as soon as possible, that would really, really help the patient's quality of life. So for the oral mucosa disorders, the mild and moderate form of it, like the form of mucositis and other things like that, erythema multiforme, typically the use of topical or systemic steroids, corticosteroids, has been shown to be effective in managing this condition. So again, they can easily be managed if they are identified early on. And patients that have xerostomia, you can talk about saliva substitutes, you can talk about sialogogues, you can talk about prescribing them some pilocarpine or cevimeline to help them with their dry mouth. And obviously, as we all know, a dry mouth also definitely has other multiplier effects. Once a patient has dry mouth, they become easily predisposed to gum disease. They become easily predisposed to dental caries. And then having dental caries, then you're talking about either doing a filling, doing a root canal, or eventually having to extract the tooth. So there's a lot of, negative downturn that could happen with this complication down the line. So definitely having a dental practitioner as part of the oncology care, very essential. And not just, being able to identify these lesions, these conditions early on, very essential, ultimately to help with the patient's quality of life. Our study obviously had its own limitation. First, we couldn't really break down the patient's demographic because we're dealing with a large database. We couldn't say, okay, this particular set of patients, were they from America? Were they from Latin America? Were they from Europe? We couldn't really break down into such groups. We couldn't really do that. Also, we couldn't really say specifically which particular ICI was responsible for what, because we had a mixture of different ICIs. We couldn't say, oh, was this pembrolizumab? Was it nivolumab? Was it this that was responsible for this particular complication? We couldn't really say that. Also, we couldn't really give you an exact timeline of sequence of when this particular adverse event occurred. Again, based on the data set that we were working with, we couldn't really, we were kind of restricted as to that. And another thing that we also need to know is that since we were looking at a large database that was already in there, we know from clinical experience that many oral complications or adverse events are underreported by oncologists. So therefore, even though we are saying it's 10%, we may actually be underreporting what the real prevalence is. Because again, our data set is based on if it was reported. If it wasn't reported, then we'll never account for it. So again, and we know in reality that is the situation whereby many oncologists tend to underreport oral complications. In summary, from our study, we were able to show that orofacial immune-related adverse events occurred in approximately 10% of patients. Neuropathy, specifically dysphagia and facial numbness and trigeminal neuralgia, were the most common form of neuropathies, followed by mucosal disorders. Clinical implications, routine baseline oral assessments are important. Basically, what I'm saying is before a patient starts immunotherapy, it would be a good idea for them to be referred to a dentist to get them evaluated to see what's going on and everything. So at least there's a baseline assessment from an oral health perspective, so that when they start this ICI, and I told earlier on, I told you that these medications could be used for up to 2 years. So that when they start these ICIs, there's a baseline understanding of what the oral health status is. And so therefore, if there are any changes, we can say, okay, yes, this is due to the medication. Maybe we need to reduce the dose. Maybe we need to discontinue for a while, or we need to interrupt this for a while and let the patient get better based on this complication before we resume it. So that will be very important. Patient education and timely interdisciplinary care will be very helpful to the patient. Some of these complications, again, can arise literally within a day. And if they do occur, it will be nice for you to have an interdisciplinary approach to managing them, somewhere you can refer them to be managed for this complication, so that the patient do not end up saying, I need to take a break from this therapy because it's causing so much pain in my mouth. It would be nice for them to know that there's a place they can go to receive timely care, and that will prevent patients interrupting their oncologic care, which is very, very important. Ultimately, The patient is the most important factor in everything, and their quality of life is more important to us. So therefore, that's a very important clinical implication for this study there. Future directions. It would be nice to actually have prospective studies conducted whereby, before patients actually start it, we know that we're recruiting them into the study to see, follow up with them. They have an oral examination on a regular basis to actually get to know what the true impact of these immune checkpoints inhibitors are. Uh, Assessing the prevalence and severity of each particular ICI will be great, and see if there's a difference in the prevalence or risk based on the PD-1 ligand, CTLA-4, or the LAG-3 inhibitors. Then lastly, it will be nice to us to understand the real the mechanistic, that is basically the pathogenesis and the etiopathogenesis of each of these conditions. What actually is leading to these neuropathies? What particularly is going on and causing these mucosal disorders? It will be very important for us to understand that, so that we can at least in the future prevent it, or at least know how to appropriately manage these conditions. With that being said, I would like to acknowledge my co-author. She is a postgraduate student actually at the Department of Pathology, University of Cincinnati. As many of you know, at ATSU, we do not have access to TriNet X. So at our institution, she has access to it. And we've been able to work, like Bat and Robin, in doing many of our studies. If I have an idea, I tell her, why don't we look at this? Look, let's use the TriNet X and let's see what we can get. And she's always willing to go into TriNet X to pull the data and see if there's something publishable from the data. And ultimately, I would definitely like to thank TriNet X for giving us the opportunity to access their database and to use it, definitely. All right, at this point, that is the end of my presentation. Thank you all for listening, and I welcome questions. I have a hand raised. Mary Jackson.
Hello. Yes, thank you so much. What a wonderful presentation. I learned a lot. So I have two comments. So I'm really happy to see that they now have a therapy for Merkel cell. So important. The second thing is I'm curious to get your thoughts on kind of combination therapy. So if you have a woman on denosumab, and then they have to do the ICI for stage 4 or stage 3 cancer. Do you think those two monoclonal antibodies would stack up and the necrosis would be even greater? Or, what are your thoughts on, because, osteoporosis is prevalent, and so a lot of people are already taking that. So just get your thoughts on that.
Thank you very much for your question, ma'am. A very, very important question. So a question is, a patient is already on denosumab, which is an anti-resorptive medication, which could actually be used to treat osteoporosis, and also actually can also be used to treat metastatic bone disease. If the cancer spread to bone, most of the medication that is being used to treat them is also an anti-resorptive, example like denosumab. Now, to your question, does that increase the risk of hemorrhage? Yes. Theoretically, yes. Now, clinically, what I want to know is, what is the denosumab being prescribed for? If it's prescribed for osteoporosis, the dose and regimen is quite different compared to when it's being used for cancer management, right? For denosumab, the brand name for osteoporosis patients is called Prolia. And with that, usually it's given once every 6 months. It's used as a tablet. So the effective dose that eventually gets into the system is much lower compared to when it's used as Exgiva, where it is given every month, every 4 weeks, and is given as a subcutaneous route. So the risk of denosumab being used for treating osteoporosis is far, far, far less compared to when it's being used to treat metastatic bone disease. So the question then comes, does the risk become really, really large? Not really, because again, if it's osteoporosis, then it's not a big dose. effectively. And again, it's once every 6 months. Then the question is, if if I'm the patient's dentist and I need to do something invasive, because the most important um triggering factor that triggers hemorrhage is invasive dental procedure. So if I need to do an extraction or do something, I would work with the patient to know when the last dose of the denosumab was given. I would typically want to work with them when the last dose is really, really far out. Like the dose was given 5 months ago. Okay. That's good to know. Because another thing also to understand is that comparing denosumab to bisphosphonates, the half-life is quite different. The half-life of denosumab is 27 days. The half-life of bisphosphonates is 10 years. So after 5 years, 5 months out, the half-life is far less, in that. So yeah, so there's a lot of consideration to think about. But theoretically, does it increase the risk? Yes. But there are other ways to work around it. And right now, in preventing hemorrhage, there's something new that we do now. We do what is called pento. The use of pentoxifylline and tocopherol can be used prophylactically in addition with timing of when the last dose was given for the denosumab. So if I ask such a patient, I will tell them, let's wait further timeline into when the last time you've used the denosumab, but also 2 weeks before the invasive procedure, I will place them on pentoxifylline and tocopherol, then carry out the invasive procedure and continue them on pentoxifylline and tocopherol, and then see how the healing outcome works out.
Interesting.
Thank
you
you,
so
ma'am.
much.
Thank you, ma'am.
We have one question in the comments from Lori. Are these initial findings being used in training our master students, or is more research needed before implementation?
Well, that's a very good question. Are we teaching ourselves? Yes. We have the good thing is that I must actually say this. My dean is here. I see him on the line. Mosdo is the only school that actually has a dental oncology clinic for pre-doctoral students. I can see that anywhere. Other schools don't have a dental oncology clinic for pre-doctoral students. They see them at postgraduate level and everything. So on Thursdays, we have a dental oncology clinic, and our students rotate through that clinic and they see all these patients and they see all these discussions and they see all this implemented in patient care. So to that question, yes.
Dr. Owosho, I have a question.
Yes, ma'am.
So do you think, first of all, how hard is it to access this TriNet X? And do you think there is any value in us getting a subscription to the?
I think there's a value towards getting it. Yes, it's a data mine. It's a huge data mine. I only use it for my own perspective. As an oral medicine oral pathologist, I can imagine what other healthcare providers in our school would like to research into. So I think there's a huge value in us getting it. Yes, there is a huge value with us getting it. I know so this was all interesting. Before we started with this old TriNet X, uh, I reached out to the editor of the oral medicine section of the quadruple journal. And I said, I have this couple of studies I have an idea on, and I have this data set. It's this database called TriNet X. And she was really excited. She was like, oh, wow, that's good. And she was asking me about Epic. I'm sure many of you are familiar with Epic in the healthcare system. She was saying, oh, she knows that Epic was trying to do the same thing too, because now most healthcare organizations are now using Epic. And Epic is connected throughout organizations, whereby you can see a patient chat if you're in Chicago and you're in St. Louis, you can actually access patient chat and everything. And she was like, "Oh, is Epic doing this now?" I said, "I don't know about Epic, but I know about TriNet X." And interestingly, what I got to know is my colleagues that are working in industries, these are PhD people, PhD doctors that are actually working in industry, in pharmaceutical industries, is in New Jersey. That's where most of these companies are. They use TriNet X for their studies, especially for their phase 3 trials. When they are trying to see complications of their medications and everything, they use TriNet X to look at those, to make such things. And TriNet X is much better than the the FAERS database. If you're familiar with FEARS database, which is the FDA database, the FDA database would only report adverse events, but it doesn't give you a denominator. It doesn't tell you how many patients who are using it. Basically it's comparing medication to medications. That is what the FDA database does. But in this particular data set, the database, we can actually see how many patients are using this medication, how many of them develop this complication or adverse events, and we can have a comparative group from the same data set, that you can actually do propensity matching. You can match as much as you want to match. And that's a wonderful study because then you can actually do a multivariable analysis, right? Looking at the impact of various variables in your analysis. So in summary, yes, it will be a great tool for us to have access to.
Do we
Thank
have time
you.
for questions?
Yes, ma'am. Dr. Panazay, how are you, ma'am?
I'm good, Dr. Owosho. Thank you for a lovely presentation. I have two questions. One, when you observed the case between the ICI intake and MRONJ in your own experience, did you write a case report and did you manage to publish it? That's my
Actually, oh, I'm submitting it for a conference. I did submit it to a conference already. So it's submitted to a conference, which is going to be in June. So it's submitted to that conference.
Nice, wonderful. My second question is regarding the data that you shared, the unpublished data from comparing, patients who are on ICI as opposed to patients who are not taking ICI medications, the 7 to 9,000 in both group. And so the prevalence of developing osteoarthritis necrosis was around 25 patients in the group that was taking ICI. I mean, even though that's like 0.03%, still, have you thought about looking into those 25 patients and their characteristics a little more closely and detailed just to see if there are any shared characteristics or features that would make one susceptible? You know,
So that's a wonderful question. Basically, from those 25 patients, we could only get their gender, we could get their average age, and again, those are some of the limitations with using the database. These are not patients I saw, so I don't have a full information on all of them. And the other, yeah, we were able to get their age, their gender, but also please note that all the confounding risk factors were already removed. Because I would, if this was a clinical database, I would want to know, have they been on anti-receptive medications? Have they been on TKIs? But in this cohort, we already accounted for all that. So at least to this point, all possible risk factors to MRONJ were eliminated from this cohort. So can say that these 25 patients did not have known risk factors for MRONJ at this point because we eliminated all that in the cohort. So are there other possible risk factors? Maybe there are, but at least the ones that we know, we eliminated for it in the analysis.
thank you.
Yes, ma'am. Thank you very much, everyone. I have to get into the clinic, and I really enjoyed presenting to you all. Thank you for the opportunity.